Hi there, and welcome to this talk brought to you by Atoza. My name is Garth. This is the final video lecture in this series that's aimed at the learning or training anaesthetist. When we were in the early stages of creating this course, we thought we would have a lecture on checking the anesthetic machine or the anesthetic workstation. Many of the lessons taught to learning anaesthetists, or the ethos conveyed to them, is around being prepared in anesthesia. Checking the anesthetic workstation is all about being prepared and reducing the likelihood of equipment malfunction during your case, which could lead to patient harm. But being prepared extends much further than just checking the anesthetic machine. In this video series, there are talks on preparing emergency drugs, on preparing the airway trolley, and John Mark gives an excellent talk on preparing for the obstetric call. So then we thought about making a video on improving anesthesia safety more generally. But that also seems a bit strange as a topic, because this whole video lecture series has had the aim of trying to improve the safety of anesthesia in the hands of the learning or training anaesthetist. So in the end, we put together this video, which is really a number of tips on being prepared in theatre, often learned the hard way on the job by us or by colleagues around us, and they're all about improving anesthesia safety. In anesthesia, it is possible for a single error or mistake to result in significant patient harm. More often though, when we look at these events or these errors, they are made up of multiple smaller errors or occurrences that in sequence lead to the final catastrophic event. An example of this could be a drug error, where an anaesthetist accidentally gives a patient the full 10 milligram ampule of phenylephrine intravenously, and that results in cardiac arrest and death. This is a terrible mistake for the patient, for their family, and for the doctor involved. It might seem like a simple error, you just gave the wrong drug. But in looking into this mistake, one may find factors that contributed to this error. For example, maybe the doctor arrived late for work and rushed the theatre preparation. Then there was also a new brand of phenylephrine on the trolley that the doctor had never seen before. The color code stickers that the doctor normally uses to label syringes had run out, and so the phenylephrine syringe was unlabeled. The doctor was distracted by someone asking them a question while they were preparing the drugs, and they were just trying to help by answering the question. And then actually that doctor was feeling very sick on the day and had contemplated not coming to work, but came to work because they didn't want to leave the rest of the theatre team short-staffed. So here we see an example of many small changes or errors lining up to lead to a major error. And this is called the Swiss cheese model of error. And basically, if you think of a block of cheese, maybe from the outside it looks like a solid block of cheese, but there are often little air pockets within that block of cheese. You don't notice them because they're scattered throughout the block of cheese. But there's a chance that each little air pocket in the cheese lines up so that it creates a tunnel right through the block of cheese. And then when you hold up the block, you can actually look right through it. And that's the Swiss cheese model of error, that multiple small errors line up in sequence to allow a channel for a major catastrophic event. So fortunately, there are lots of times in medicine when errors don't cause significant patient harm. And this is normally because of backup safety systems or safety nets within the system as a whole, or the team around us provides extra levels of patient safety that can correct for our errors, such as checklists, built-in safety steps, preparation for complications, training in early detection and managing complications, and there are other safety levels as well. So this video will hopefully give you some tips on small things you can do or change in your practice to add extra levels of safety. And like I say, most of them are based on hard experience learned by us in clinical practice. So let's start by looking at a few points on general theatre preparation. Whatever theatre complex you work in, whether it's your regular place of work or if it's a new venue for you, you want to make sure that you are familiar with the resuscitation equipment available in theatre, and that theatre has a system in place for the checking and upkeep of that equipment. For me, practically, this means I want to know exactly where the resuscitation trolley is, and I frequently look through the various drawers of the resuscitation trolley to have an idea of what equipment is inside, and also so that I can make suggestions to the theatre management team if additional equipment is required. So as an example of this, a common drug that is seldomly available in theatre is the short-acting beta agonist bronchodilator. And if you watch the videos on ventilation and ventilation complications, we'll go through how to administer metered dose inhalers or bronchodilator inhalers down the endotracheal tube. And in the theatre complexes where I work, unless the patient comes to theatre with their own pump, there isn't actually a pump available in theatre. So should we have an unexpected acute bronchospasm, that drug is not available in most of the resuscitation trolleys that I come across. And so I have to go to theatre managers and say, please, can we have this pump available on our resuscitation trolley? So that's one particular drug that I think is really important that we have in theatre that isn't on the resuscitation trolley. Secondly, in particular, I also want to be very familiar with the defibrillator that is normally kept on the resuscitation trolley. And this is because there are lots of different makes of defibrillators, and they're all slightly different. So I want to carefully inspect the defibrillator that's available for me, and I want to know, do we have defibrillator jelly? Do we have AED pads that we can stick onto the patient's chest, or do we have to use the manual defibrillation pads? And then in particular, I also want to know if that defibrillator has the option of bradycardia pacing, because not every defibrillator has that. And I've been in resuscitation situations where a defibrillator has been brought and we can't do bradycardia pacing with that defibrillator. So I want to see that we can do bradycardia pacing. I want to know how to attach the ECG electrodes to the defibrillator to do that. I want to know how to attach the AED stickers to the defibrillator, because that's what we use for bradycardia pacing. And then I want to know how to turn on the pacing mode, how to adjust the rate of the pacing, and how to adjust the electrical output from that pacing. So in future, we aim to have a talk on certain aspects of resuscitation, and I think that will be beneficial for everyone. But just as a starting point, find the defibrillator in your unit and get someone to explain to you how to use it safely, and just practice with the different attachments, and in your mind go through how you're going to use that if you have a situation of a severe symptomatic bradycardia. Then thirdly, on general theatre preparation, I want to know exactly where the difficult airway equipment is kept. It should be kept in a clearly labeled box saying difficult airway box, or in a trolley that says difficult airway trolley. I want to know where it is, and I want to know what is inside. And the three things that I'm particularly interested in with a difficult airway trolley or difficult airway equipment: is there a video laryngoscope available? Where is it kept? What make is it? Is it plugged in and charging? Then I also want to know if the theatre complex has a pre-packaged cricothyroidotomy set. So you can buy commercially available pre-packaged sets for doing a surgical cricothyroidotomy. And if there isn't one available, then I want to assist that theatre complex in putting equipment together and labeling it, so that in the event that one has to do a front of neck airway, all of that equipment is ready. And in our airway talk, you would see that that equipment would be a gum elastic bougie, it would be a sharp-tipped scalpel, and then a size 6 endotracheal tube, so that that equipment is ready if and should I need it. And then in my particular setting, I also want to know if there's a fiber optic bronchoscope available, Obviously, this isn't a piece of equipment that's available at every hospital, but if one's giving anesthetics to sick patients, we may need to do a bronchoscope to clear mucus plugs from the lungs. Any patient that vomits and aspirates, we obviously need to do a bronchoscopy there to clear their airways. And then this is a piece of equipment that one can use for awake intubations. So that's not standard equipment at every hospital, but in my setting, that's something that I always ask whether it's available or whether it's broken and being sent away for fixing, because that will change how I think about my anesthetics on that day. So in addition to checking the resuscitation equipment, difficult airway equipment, there are two specific drugs that we need to be familiar with as anesthetists that are not often on the resuscitation trolley itself. The first one is Intralipid, and that's for the management of systemic local anesthetic toxicity, and then Dantrolene for the management of malignant hypothermia. In this video series, we haven't spoken about complex nerve blocks or regional anesthesia, and so we haven't gone into managing local anesthetic toxicity. In my practice, I do a lot of regional anesthesia for painful orthopedic procedures, and so every time I'm starting a list, I want to make sure that Intralipid is available, that it hasn't expired, and I know exactly where it is in the theatre complex. And then obviously, malignant hypothermia is an anesthetic-specific complication that can occur at any time, and so your theatre complex has to have a malignant hypothermia treatment protocol and Dantrolene available. Remember that malignant hypothermia untreated has got a mortality rate of more than 90%, but if one recognizes it early and initiates treatment, the mortality rate is less than 10%. The next piece of equipment to check is the equipment for giving controlled intravenous infusions. And these could either be pumps that control infusions down an intravenous line, or it could be a syringe driver pump. And again, there are lots of different makes. They're all slightly different. And so I want to make sure that I am familiar with how to set up that equipment, because there are a lot of anesthetic or surgical complications where the end result is an adrenaline infusion. And so I want to be able to do that safely. And then also if I'm giving any intravenous anesthetic drugs in a TIVA or TCI, I want to know how to do that. Okay, so those were some tips on general theatre preparation. So now moving on to preparation within the theatre which I am working. I think in general anesthesia training highlights the importance of checking the anesthetic workstation, checking the airway equipment, and preparing emergency drugs. So I'm going to focus on some other tips from my practice. So firstly, the ambu bag is the most important piece of ventilatory equipment in the hospital and in theatre. This is because it is a self-expanding reservoir bag. So you don't need any fresh gas flow into it. You don't need any external gas. The bag will expand itself so that you can give the next breath. And then also, it has far fewer mechanical components, and so it's less prone to failure than a mechanical ventilator. I think this device is so important, I would go as far as saying that you should never give an anesthetic without an ambu bag available in your theatre, and that's certainly how I was trained. You do need to check, though, that the ambu bag is working, and this is probably where the anecdote comes in. It hasn't happened to me in theatre, but I've been called to resuscitations in the ward setting and got there, and there either hasn't been an ambu bag or the ambu bag has been non-functional. So I just want to talk you through how I check the ambu bag before I start any list in theatre. So the first ambu bag we're going to look at here is an adult ambu bag. I've just taken it off the resuscitation trolley. So the first thing that you want to check is that you have oxygen hosing so that you can connect it to an oxygen outlet. You then want to check that there is an oxygen reservoir bag at the back of the ambu bag. And then we're going to actually check the workings of the ambu bag. So the first thing is to check that you can generate a positive pressure. And we do that by occluding the outlet of the ambu bag and then squeezing the ambu bag and seeing that we can generate a pressure. you'll notice that this ambu bag doesn't have a pressure release valve. So when we squeeze this ambu bag, we're able to generate very high pressures. So we have to be careful about that. But I'll show you an ambu bag just now that does have a pressure release valve. So we show that we're able to generate pressure. The next thing that we want is to be certain that the bag is going to reinflate. So an ambu bag is a self-expanding reservoir bag. So it doesn't actually need any gas going into it to reinflate. It will draw in room air from the back of the ambu bag. So to test that it's going to reinflate, we get all the air out of it. We occlude the outlet, and then we let go, and you see the bag is re-expanding. And that is because it is sucking air in through the back of the bag. The outlet was occluded, so it's not sucking air in backwards. It's sucking it in through the back of the bag. And then the last thing that we want to do is we want to be certain that the patient can exhale while the ambu bag is connected. So we know that we're able to generate a positive pressure breath, but when we let go, is the chest going to be able to exhale and decompress? And there's a separate valve in the inside for that. And the best way to test that is by taking your reservoir bag of your anesthetic machine, and I normally just scrunch it up a little bit so that it's got a smaller volume. I can connect it to my ambu bag, and then I can check that I can inflate my reservoir bag. But if you see, the reservoir bag is deflating on each exhalation as well. We can get air into it, and then air can freely move out of it on exhalation. So now we know that this ambu bag can generate a positive pressure. It can reinflate on its own. We've got oxygen hosing, so we can add extra oxygen if we need it. And then also the patient is going to be able to exhale. So then just looking at a different ambu bag, this just happens to be a pediatric ambu bag, so very similar, but I just wanted to show you here the pressure release valve. So this pressure release valve is set to not allow you to generate pressures more than 40 centimeters of water. So we can generate a positive pressure, but as soon as I squeeze too hard, the air doesn't come out the outlet, the air comes out the pressure release valve. So that's a safety feature on this ambu bag to prevent you from causing barotrauma to the lungs. There are some circumstances though where that might cause some problems. For example, if you were trying to ventilate someone who had acute bronchospasm, unfortunately in that situation you might need to use inspiratory pressures of more than 40 centimeters of water. And so what you can do then is while you are bagging the patient, you can actually hold in the pressure release valve. And that basically negates the effects of the valve. And now you can see that I'm able to generate a very high inspiratory pressure. So that's not something you want to be doing often because you're going to be causing damage to the lungs. But there might be some rare examples where you need to occlude this pressure release valve so that you can generate higher pressures in an emergency situation. But for the most part, that valve is there to prevent you from causing damage. The same applies in testing this ambu bag. We now know that we can generate a positive pressure. We know that the bag will re-expand and reinflate from the back. And then again, we can check that the patient is able to exhale by connecting a reservoir bag, by filling it up with air, and we can see inspiration, expiration, inspiration, expiration. So the expiratory valve on the ambu bag is working. And that's how you check an ambu bag to make sure that it's going to be there, ready to use when you need it in an emergency. So this brings us to another really important safety point, and that is checking the availability of oxygen in theatre. We check the availability of oxygen during the anesthetic workstation check, and there's two steps to that. The one is checking that there is piped oxygen to the machine under adequate pressure, and then checking that there's an oxygen cylinder on the back of the machine and that cylinder is full and it has enough pressure too. I then also know where extra bottles of oxygen are in the theatre complex, so I know that the resuscitation trolley has got a full bottle of oxygen, and I know that there's also extra bottles of oxygen in the post-anesthetic care unit or in the recovery room. There are other safety checks regarding oxygen in the anesthetic machine check, such as dumping of nitrous oxide, an oxygen alarm, oxygen sensors to measure inspired and expired oxygen levels, and then we of course have a SATS monitor to check for hypoxemia. So oxygen is really important in theatre. So at the beginning of every morning or the beginning of every slate, we are meant to check the anesthetic workstation. But I've learned the hard way that checking certain components of the anesthetic workstation can't just be done once a day, and specifically relating to the circle system. So before the start of every anesthetic, I want to check that I can create a positive pressure within the breathing circuit or within the circle system. And this is because that on 2 occasions in my career, I've had damage to the circle system between cases. So I've been doing a list or I've been doing a call and everything's been working perfectly. I checked the machine at the beginning and I've had no problems during the cases I've done. And then I've started a new anesthetic and suddenly I'm unable to ventilate that patient. Fortunately, in both of those situations, I had an ambibag immediately available and I was able to bag the patient using the ambibag on supplemental oxygen. And the one case, what had happened was someone had moved a trolley over the reservoir bag and there was a big tear in the reservoir bag. And in the other case, there was a big crack in the tubing of the circle system and I was unable to ventilate. So now before I start any anesthetic, I check that I can create a positive pressure in the circle system. Okay, so how I check the breathing circuit in between cases is I grab the end of the breathing circuit, I occlude it with my thumb. I then close the APL valve. So I close that to 70. I can then set my fresh gas flow at less than half a liter per minute. So I set that on the ventilator. And then I can press the oxygen flush on the ventilator and watch the bag. So I can flush the bag fills, I'm occluding the end, and I can see that I am maintaining pressure within the circuit. So I'm not adding much fresh gas flow, and the pressure is maintaining in the circuit, and the bag is not emptying. And then I can watch on the ventilator graphics as well that I'm able to maintain my pressure. Normally then the anesthetic machine starts alarming because you generate a pressure that's quite high and it starts alarming and you have to silence those alarms. But then I know that everything's working. I can create a pressure and then I also know that my high pressure alarms are working and I can safely start my anesthetic. So the one example which was particularly terrifying was a patient that had, I think, a stabbed chest, had a pneumothorax, and the knife had actually hit the heart. So it was a stab heart, stab lung scenario. The patient was rushed up to theatre. I'd literally just taken another patient off the operating table, rushed the patient into theatre, gave the drugs, put the endotracheal tube in, and tried to ventilate the patient, and I couldn't generate a pressure. And that could mean that there's a number of things that have gone wrong. Either there's a massive air leak within the patient's chest, or my endotracheal tube is in the wrong position. There's a whole lot of terrifying things that go through your mind. And so I grabbed the ambibag and I started bagging with the ambibag, and we got beautiful chest rise. And then I knew that my airway was fine, that there wasn't a big air leak from the patient's thorax. And we then saw that the reservoir bag was torn and we were able to change the circle system and everything was fine. So that was quite a terrifying experience. I think this also brings me to the point where often when we're thinking about complications in anesthesia, we picture a totally calm, elective, serene scene where everything else is going well, and suddenly then you have a leak or you have a bronchospasm or you have an anaphylaxis, but everything else is under control. And the reality is that these complications can happen in any patient. So the next piece of equipment that we check as part of our anesthetic machine check, but that I check between cases, is the functioning of the suction apparatus. So we want to obviously check that the suction apparatus is able to generate an adequate negative pressure, but where it often fails between cases is where the new equipment or the clean equipment hasn't been attached properly. And there are 3 areas where I find frequent problems. The one is that the suction canister is not clipped in properly, and so you can't actually generate suction. The other is that the suction hosing is not attached to the canister tightly, so that when you pull on that hosing to use it, it disconnects, and then it even frequently disconnects from the Yankauer. So between cases, I make sure that the suction is clipped in properly and that the hosing is applied tightly. And again, there's a difference between using your suction if there's a bit of secretions or a bit of blood in the back of the throat, and using your suction for a vomiting and aspiration scenario. And I've had patients vomit on induction or vomit on emergence, and the amount of fluid and particulate matter that comes out is large. We're not talking 10 mils, we're talking 200 mils, 500 mils of fluid that comes out. And when that happens, the only thing that's going to get you out of that trouble is having suction that is working perfectly, and every second counts. So suction, really important, and really important to check it between cases that it's still working for the next patient. Right, so then let's move on to checking the anesthetic trolley itself, which is the trolley that contains all the anesthetic drugs and syringes and additional equipment. I like to check the anesthetic trolley thoroughly at the beginning of my list to make sure that it's well stocked with all the drugs and equipment that I may need. And what I don't want is my anesthetic assistant running in and out of theatre, collecting single items as I need them, because then we're distracted by that and that person is out of the theatre when I might need them in theatre. And so I like to look through the trolley, and I know the type of drugs and equipment that I like to use in my style of anesthesia, so I make sure that they're available. Things that I might want that other anaesthetists might not want is I always want a pressure bag in theatre, so I can give intravenous fluid under pressure and get fluid faster into the patient. I have a low threshold for using temperature probes in theatre for my anesthesia, so I always want those available. I like to have soft suction catheters available, so not just the rigid suction catheters for suctioning the mouth. The soft suction catheters that we can put down the endotracheal tube to suck out secretions, aspiration contents, mucus plugs, and then also to check the patency of my endotracheal tube that it hasn't kinked in the back of the throat. So I like to have those available. And then a drug that I might use that other anaesthetists don't use as much is intravenous magnesium sulfate to blunt intubation responses or to correct hypertension in patients under anesthesia. And then while on the topic of the anesthetic trolley, I think it's a good time to talk about drug safety in theatre. So drug errors are really common in anesthesia, and they can have devastating consequences. Certain drug errors, such as intrathecal rocuronium or cyclocapron, so that is giving rocuronium, the muscle relaxant, or cyclocapron, the procoagulant drug, in a spinal or epidural anesthetic into the central nervous system. Those drug errors are fatal in the majority of cases. So if you make that mistake, that patient is going to end up paralyzed or they're going to die because of your drug error. So there are a few steps that I rely on to try avoid drug errors. So I try to eliminate distractions while preparing drugs. So I try to have my phone away. I try not to have conversations with the other team members while I say to them, just hang on a second, let me finish drawing up these drugs and then we can talk. I read the label on every ampule before I aspirate the contents into a syringe. And then after I've aspirated it, I read the label again. So I'll pick up an ampule and I'll say, okay, dexamethasone 4 milligrams, open it, draw it up, look at it again, dexamethasone 4 milligrams, and then put it into my container. So this is a form of double checking. I label every syringe with a color-coded sticker. And there's a universal system for what colors are used for each drug. So we use red for muscle relaxants, we use blue for opiates, we use yellow for sedative drugs, green for anticholinergic drugs such as atropine or glycopyrrolate, purple for inotropes or vasopressors like adrenaline, noradrenaline, ephedrine, phenylephrine, and then a green and red sticker on my syringe containing neostigmine and glycopyrrolate, and those are the reversal agents. I also have plain white stickers available on which I can write the other drug information for other drugs that I use, such as antibiotics, anti-nausea medication, cyclocapron, and other drugs. So every syringe has got a sticker, and every sticker has got a drug name and concentration on it. So fentanyl, 50 micrograms per ml. Morphine, 1 milligram per ml. Every syringe has a sticker. Every syringe has a drug name and concentration. And then the next point of drug safety is around infection control. So I try to be meticulous in my infection control measures regarding drugs too. I never take a dirty or used syringe back to the anesthetic trolley. I keep my syringes capped at all times. I keep my syringes for the patient that's currently in theater in a kidney dish on the anesthetic workstation table, far away from the anesthetic trolley. I keep my emergency drugs in another kidney dish on top of the anesthetic workstation, so I know where they are, and they're separate to the drugs that I'm using for the patient in theater, and I'm less likely to give them as a drug error. But I know where to find them. At the end of a case, I clear away all the syringes and needles and caps that I've used for that patient in theater, and I do that before the next case is brought into theater. Accidentally giving a patient a drug from a used and potentially contaminated syringe is gross and it's negligent, and we all need to work hard to make sure that that doesn't happen. The next point that I was taught early on in my anesthetic career to be very particular about, and that was around theater layout. I'm not sure how one can provide safe anesthesia in a messy, disorganized environment. That may be fine when things are all going well, but in the event of an emergency, any mess or disorganization is going to contribute to bad patient outcomes. So I want my theater layout to be clean and organized. I want a clear line of path between my anesthetic trolley and the patient, so I can move between the two safely and quickly. In particular, I don't want cables and tubes and pipes on the floor or blocking my ability to get to the patient's airway or the anesthetic workstation. There are obviously times when access to the patient is limited, such as in head and neck surgery, upper chest surgery, shoulder surgery. But for these cases, I never compromise my comfort or safety at the critical times of induction or emergence from anesthesia. What this means for me is I have the patient positioned in the optimal position for me to provide safe anesthesia at induction and at emergence. And once the patient is safely asleep, then I can reposition the bed or the equipment for the surgery. Also, in these cases, it's even more important that the patient is positioned safely, the tubes and pipes and monitors are all secured and safely lying so that they don't get accidentally pulled out or disconnected, and they're not impeding my ability to access the patient. There are other aspects of theater safety that are important too, such as electrical safety, liquid safety, fire safety. These cannot be compromised on, and although accidents are rare, it doesn't matter how good your anesthetic was or how safely you got the patient through their high-risk procedure. If they wake up with an electrical burn or a chemical burn, or someone slips and injures themselves during the operation, well then that whole operation has not been a success. Theater layout has a massive impact on infection control. So I do a lot of anesthesia for orthopedic procedures, where one of the biggest things we're worried about is infection in prosthetic joints, and our team is pedantic about infection control. How we move around the theater and the risk of contaminating sterile equipment is really important. And again, this comes back to theater layout. Right, so we've covered some tips on theatre preparation. Let's now go through a few points on preparation for each case that we're bringing into theatre. One thing that I was taught early on was to try see my patients preoperatively as early or as soon as possible, elective, and then especially emergency patients. The most obvious reason for this is to give you an opportunity to perform the necessary investigations or optimization of the patient before the procedure. But don't underestimate the value in having time to reflect and consider each individual patient's requirements. An anecdote about this would be the countless number of patients we would anesthetize at night for diabetic septic lower limbs, coming for debridements or amputations. These are sick, old patients, and the standard approach was a simple spinal anesthetic. But I had patients arriving in the theatre complex with heart rates of 150 beats per minute, with acute arrhythmias, with obvious myocardial ischemia on their ECG, in pulmonary edema, in diabetic ketoacidosis, and I quickly learned that I needed to see these patients as soon as possible and early in my call to be involved in their preparation, including fluid resuscitation, analgesia, blood tests. And what this meant was that far more patients arrived in theatre, normotensive, not tachycardic, relatively comfortable, and they could have a safe, simple spinal anesthetic. And those patients who, despite my resuscitation efforts, arrived in theatre still acutely unwell, well, then I knew that these were very high-risk cases, and they needed different workup, different monitoring, different type of anesthetic, different post-operative care. So that's the first point, to try to see your patients as soon as possible, to optimize them, but also to have your anesthetic plan evolve with time. Then the next tip, whatever anesthetic you're planning on giving, always be prepared to perform a general anesthetic with the patient paralyzed, with an endotracheal tube and ventilation on an inotrope infusion. This is because no matter what type of anesthetic you start with, the end result of severe complications in theatre is a general anesthetic on life support. So for me as a training anesthetist on call, this meant having airway equipment available, an appropriate sized endotracheal tube out and ready to be used. It meant having an induction agent pre-drawn and labeled, which was normally ketamine. It meant having a muscle relaxant pre-drawn and labeled, which was succinylcholine. It meant having atropine pre-drawn and labeled in a syringe, and then vasopressors such as ephedrine and phenylephrine pre-drawn and labeled. And in my scenario, I also always had adrenaline pre-drawn and labeled for an infusion. There are so many complications that can occur rapidly in anesthesia or surgery, and at any time during the procedure, including right at the beginning. And you don't want to be scrambling to draw up drugs while trying to manage the patient. Just think about vomiting and aspiration, bronchospasm, anaphylaxis, missed cardiac lesions that result in acute stability or acute pulmonary edema. These are not complications where we have time to be looking for drugs or be drawing up drugs. So be prepared. Another piece of advice I received early in my training was to never wheel a patient into theatre without a clear plan of action. The reason being that once you are in theatre, the pressure to continue with the case, because the team is waiting for you, means you could start something you aren't ready or prepared for. So you wheel the patient into theatre, you're not quite sure, is this patient sick? Are they shocked? Do they need more fluid? What's going on? But now you're in theatre and everyone's waiting for you. And so you rush and you start your anesthetic, and that results in severe, profound hypotension or cardiac arrest on induction. Much better to assess the patient fully outside of the theatre and to make a plan. So I was told to make a plan first, prepare my drugs and equipment, and then bring the patient into theatre. I found this advice extremely helpful. as I felt that when I brought the patient into theatre, I had my plan and my tasks clearly arranged in my mind. And I wasn't as anxious with indecision or uncertainty, although I may still have been stressed about having to look after a sick patient. So for example, the plan could be as simple as, I'm going to do a spinal anesthetic for this case. I'm going to use 2.8 mils of bupivacaine, 0.5% local anesthetic. If for some reason this fails, I'm going to do a rapid sequence, general anesthetic using propofol, succinylcholine, and a size 7 endotracheal tube, and a size 3 laryngoscope. And if I have difficulty, I suspect that mask ventilation is going to be easy and that the use of a supraglottic airway will be successful. Okay, right, I've got a plan, let's go. On busy calls, this brings us back to preparing the theatre at the start of the call for the catastrophic emergency, whether this is a complication during your case or an unstable emergency patient, such as an antepartum hemorrhage that is rushed to theatre. If your theatre is prepared for these cases, and you are mentally prepared in terms of your actions and switching from a controlled situation into an emergency situation, then these patients can be brought into theatre quickly and still safely. Okay, so seeing patients in advance of surgery has the benefits that I've stated, but then remember to review your notes and your assessment and your plan before taking the patient into theatre. So I've definitely made mistakes where I've seen patients in advance, I think I remember everything about them, and then I've forgotten that there were certain things that I wanted to check. I wanted to check the UNE to just find out what the potassium level was, or I forgot that the patient was actually potentially allergic to an antibiotic, and then I've given that antibiotic by mistake. And then there was one case where the patient was on a generic form of an antiplatelet agent, and I hadn't had a chance to look up that drug and actually check what it was. I didn't know that it was a potent antiplatelet agent, and I went and did a spinal anesthetic in that patient, and the patient bled during the surgery, and it was all because I had forgotten that one of my tasks was to check what that exact drug was. Fortunately, it all ended well and there was no harm, but when I spoke to my seniors about that, it highlighted the point that I had made a plan, I'd written down, this is what I need to check, this is what I need to do, this is still what's pending, but then I forgot to read through those notes when I brought the patient into theatre, and luckily I've got away with those errors, but lesson learned. Always check your notes before you bring the patient into theatre. The next tip is to do the WHO surgical safety checklist. So wherever I've worked, whenever they've done audits of adherence to the safety checklist, it's been pretty poor. And I must admit that there are periods where I'm good at it and there's periods that I'm not good at it. But it is an excellent checklist to do, and it's been proven to reduce theatre complications and error. And if you don't do the checklist, and then you or the team makes an error which could have been adjusted for by the checklist, well, then you're going to feel terrible. And also from a medico-legal point of view, you've omitted something that has been shown to reduce complications. So lead the way, be the person that takes the responsibility upon themselves to lead the team in this practice-changing behavior. As part of the WHO surgical checklist, there's an opportunity for you as the anaesthetist to announce your concerns to the team. Use this opportunity. Don't think, oh, I'll just manage by myself, and what does the surgeon know about difficult airways or about cardiac risk or about arrhythmias or any of those things. Announce your concerns to the team, and you'll be surprised at how often the team can help you do your job better. And again, this has been proven that the team works better when information is shared. So you can say, I'm worried that this patient's blood pressure is going to drop precipitously on induction of anesthesia. I'm worried that intubating this patient may be difficult and that his beard may make mask ventilation difficult. As I said, your team will often surprise you in their helpfulness or the quality of suggestions, and you will learn and benefit from this. So surgeons have offered to hold the cricoid pressure so that the anesthetic nurse can just be focused on helping me. That's a big help. Surgeons have said they also want to look at the front of neck airway kit before we start an anesthetic, so that if we do have to do a front of neck airway, they can be prepared to help me. I've had surgeons put in high flow intravenous lines for me or arterial blood pressure lines for me while I perform other tasks. Nurses have appropriately suggested using a different size of endotracheal tube or a different airway device in a patient based on their experiences. Scrub sisters have communicated more regularly or more clearly about intraoperative bleeding when I have said I'm worried about bleeding in this patient. And we've made better team decisions on postoperative care choices such as intensive care or ward care, ventilation or extubation. So do the WO safety checklist and report your concerns to the team. And then the last tip, which we have covered in detail in the other talk on ventilation, is just pre-oxygenate your patients before the induction of anesthesia. Why have seconds of safety when you can have up to 8 minutes of safety? Pre-oxygenate for every case. And then when you have the very rare case of bronchospasm or aspiration on induction or a failed intubation, you'll be so grateful that you adopted this habit, because the patient won't desaturate until much later in the process and you'll have time to get them through it. What I do to speed up this in my anesthetics, because I get frustrated waiting 3 to 5 minutes to pre-oxygenate a patient, is as soon as the patient gets on the operating table, I give them the mask to hold. They can start pre-oxygenating themselves while we are attaching monitors and while I'm putting in an intravenous line. And so that way the pre-oxygenation is already almost halfway completed by the time your hands are free to hold the mask yourself, and then encourage the patient to take a few really deep breaths and get that pre-oxygenation up to an exhaled oxygen level as close to 90% as possible. Okay, so let's move on to some tips now that I've learned to do during the surgery. So the first tip here is all about patient positioning and safety. Again, it doesn't matter how good your anesthetic was in terms of airway management, in terms of hemodynamic control, lung protective ventilation, multimodal analgesia. If your patient wakes up with a pressure sore, a burn, a neuropraxia, or an ulcerated cornea, you're going to feel terrible and the patient is going to be extremely unhappy. So take care in protecting the patient. And although many aspects of patient safety in theatre are a shared responsibility by the whole team, we as the anaesthetists are the ones that are taking away the patient's ability to protect themselves. So we need to be vigilant throughout the case, and we need to lead the team on protecting the patient from eye trauma, such as corneal abrasions from foreign bodies rubbing against the eye, or corneal ulcerations from the eyes drying out during the case, or pressure damage to the eye. And I have recently had a patient wake up with a corneal ulcer, despite us using gel in the eye and taping the eyes closed, and it was extremely uncomfortable for her, and it had me very worried up until the time it healed without complication. Then we also need to pay careful attention to protecting the patient's pressure points against ischemia and nerve damage. And I've recently had an elderly patient who had a neck of femur fracture, and we did a total hip replacement for her in the lateral position. And she woke up from the procedure and her dependent arm had obviously had some pressure on her brachial plexus, and she woke up with an ulnar nerve neuropraxia. Initially no motor function in the ulnar nerve distribution and sensory loss, and currently it's resolving and she's got her motor function back and the sensory component is improving too. But that's been a practice-changing event for me. And now what we're doing is we're putting a jelly pad just below the axilla in the lateral position to take some of the pressure off the shoulder and the dependent brachial plexus. So protecting against pressure-induced injury is really important. And then I've heard of recent cases of chemical burns to patients from the alcohol cleaning solution that's used to clean the surgical site, and this can track underneath the patient's back or buttocks and result in burns. We need to focus on protecting patients from diathermy burns so that the patient has no contact with metal in theatre. And then in the elderly population, we need to protect the skin from abrasions and lacerations during movement or positioning, because this is really common in frail elderly patients and places them at risk of wound sepsis, of cellulitis, and other problems. The next and probably most obvious point on anesthesia safety is to be present in theatre at all times during the anesthetic. If you do need to leave the theatre, for example, to attend to a patient in the recovery room or for a quick toilet break, then try to have a colleague relieve you or have your anesthetic assistant watch the monitors for you. But these should really be the exception, not common practice. We need to be in theatre all the time watching our patients. And every minute that you are out of the theatre, you are placing your patient and yourself at risk. Following on from this, when you're in theatre, pay attention. And there's so much that can be said here regarding watching the monitors, watching the surgery, anticipating events, and more. I'll just give you a few tips that I use daily. I want the volume of my pulse oximeter loud enough that everyone in theatre can hear it. The pulse oximeter gives us information about the heart rate, the rhythm, oxygenation, and then possibly also ventilation. It also gives us indirect information about perfusion. And a change in the pulse oximeter tone is rapidly and easily identifiable by everyone in theatre. So I want everyone to be able to hear that. There's some theatres that I walk into and you can barely hear any monitors. You've just removed a big layer of safety, in my opinion. I then also like to adjust the alarm parameters for each patient to try and make them more patient-specific. For example, there's very little value in having a tachycardia alarm set at 100 beats per minute for an 85-year-old patient who has a starting heart rate of 55. By that point, the heart rate has doubled and it's near the maximum heart rate for that patient. So if the heart rate baseline is 55, then I want to set my heart rate alarm, my tachycardia alarm at 75 or at 80 so that I can get alerted early. And the same may apply to blood pressures. In this patient who has a baseline blood pressure systolic of 150, having the blood pressure alarm when the systolic hits 90, that's too low. I wanted to alarm when the systolic is below 120. So I try to make my alarms more patient-specific, and then the anesthesia workstation or machine can help me do my job. It means that I can be drawing up drugs or writing a script or answering a phone call from the ward about a patient now who's having nausea after an anesthetic. And I know that while I'm doing those things and I'm slightly distracted, my alarms are going to help me. Then I watch the surgery. Not all the time, but I make sure that I'm watching during the critical steps for sure, and then regularly in between too. I want to know where we are time-wise. I want to get an impression of whether things are going smoothly or whether the surgeon is having problems. I want to anticipate the surgeon's next request, such as position changes. And then I also like from time to time throwing out some sage surgical advice or wisdom, just to keep the surgeon on their toes. No, but jokes aside though, you'll be surprised at how often you can help just by watching the surgery, by offering to adjust the height of the operating table, for offering to adjust the position of the lights, by telling the surgeon, hey, your diathermy is about to fall on the floor, or noticing that a swab has fallen on the floor and that's going to affect the swab count at the end. You can also watch and help with the sterility of your team. Sorry, but you just touched something unsterile on the way to the operating table. I think you need to scrub again. In the theatre teams that I work in, we've built trust in our relationships where this type of communication is appreciated. And there's communication in both directions, and it's always for the benefit of the patient and the team. I also watch the blood suction canister, the swabs, the drapes, and the blood on the floor. During high-risk procedures, I'm watching this and all my monitors all the time. It's so easy to fall behind 1,000 mils in your fluid resuscitation. If you don't have direct line of sight on these items, the surgical team often gets tunnel vision. They're seeing the problem, they're trying to stop the bleeding, and they're focusing here, and they're not seeing the big picture of all the bleeding that's happening around them. And so I move around the theater, I watch what's happening, I listen to the suction. You can hear when that suction is sucking up a lot of blood. And then I want to keep up with my fluid resuscitation. So I guess a number of these points can be summarized by saying that what I aim for is early intervention in theater, early intervention in steady progressive bleeding, early intervention if the blood pressure is trending down. I'm very proactive when it comes to blood pressure management. I don't want to see hypotension in my theater, and I certainly don't want blood pressures less than systolics of 90 in adult patients, or systolic blood pressures less than 20% from the normal baseline. And the big concern here is that hypotension causes acute kidney injury, it causes myocardial injury, and so I intervene early. And then one of the other areas where I intervene early is when the oxygen saturations are trending down. So we started a case and the saturations were 98% on the ventilator, and now they're trending down and they're at 93%. I don't wait until they get to 90% and the alarms start going off, because by that point we're already on the steep part of the oxygen dissociation curve, and the SATs could be 60 within a matter of seconds. So I want to intervene early. What's happened to my ventilation? What's happened to my inspired oxygen concentration? How are my flow volume loops looking? Have we de-recruited? Do we have atelectasis? Are there secretions? I want to intervene and I want to get those SATs back up to 96, 98% and have my patient in a nice, safe, comfortable area. Right. So let's now move on to the last phase of the anesthetic, which is emergence from anesthesia and then the period in the recovery room. So in my experience in anesthesia over the last 12 years, I generally find that during the induction phase, the theatre team as a whole is normally paying attention to what's going on in terms of the anesthetic. They're aware that the patient is awake, that the patient's anxious, so everyone tends to be quite quiet and they're all getting on with their jobs of getting the theatre ready to perform the surgery and to assist me with the induction of anesthesia and to make sure that the patient is safe. Then during the surgery, I also find that the team is normally very focused on helping the surgeon perform their task as safely and as quickly as possible. But at the end of the anesthetic, this is normally the most noisy time in theatre where the team is paying the least attention to the patient. But it's actually the most dangerous time of the anesthetic. More complications happen on emergence than happen on induction or during the surgery. And so what you want to encourage with your team is that they are aware of the things that could be going wrong. They're aware of what your concerns are and your steps in managing those, and that everyone is performing their tasks quietly and ready to assist you during this difficult time. And here again, the surgical safety checklist can help you, because at the end of the operation, there's certain things that you have to go through. And one of them is to announce any post-operative concerns or any concerns you have at the end of the anesthetic. And so you could say, I'm really worried about extubating this patient because I had difficulty in intubating them at the start of the anesthetic, and they're quite overweight, and it's been quite big, painful surgery. And so I'm worried that they're going to have pain, they're not going to breathe properly, their weight is going to contribute to small lung volumes, and that we're going to extubate this patient, that they're going to be hypoxic, and we're going to struggle. And then the team can assist you in that, and they can offer advice, or they can just help by being prepared to help you. This whole period of focus then extends into the recovery room when we deliver the patients now to the recovery room, which is a new venue. There's now a new team member, the recovery nurse, who has to look after the patient. We have to attach new monitors to the patient, and things could have changed in transit to the recovery room. And the patient is still often in the emergence phase from anesthesia. They haven't reached a point where they have adequately recovered from the anesthetic, and that's why they're in this holding area for their own safety. And so there are a few things that I try to take care with when delivering patients to the recovery room. I want to be involved in attaching the monitors to the patient, so I know that they are attached correctly, and I want to see the first set of vital signs, the saturations, the blood pressure, the heart rate, and the ECG. I then want to hand over to the recovery room nurse some details around the anesthetic, the surgery, and what any concerns are I have for this patient in the recovery room. Before I walk away from that patient, I want to make sure that the airway is patent, that there's good flow on inspiration and expiration by the patient. And here we commonly see in the sedated patient a bit of stridor, sleep apnea, or hypoventilation. If we apply supplemental oxygen to the patient, I want to see how much oxygen we're applying, and I want to see that it has the desired effect before I walk away from the patient. And then one of the common things that we experience in the recovery room is pain and nausea. And I want to have a clear plan for the recovery room nurse on how to manage those or when to contact me. So while the patient is in the recovery room, they're still my responsibility. And especially now, if we are moving on to perform the next anesthetic and we're wheeling the next patient into theatre, I want to make sure that this patient is stable before I take on any further responsibilities that prevent me from getting back to the patient. Obviously, there can be situations where a patient in recovery who was looking good now has a complication, and now my attention is shared between a new anesthetic in theatre and a problem in the recovery room. But we want to try to keep that to a minimum, and we can do that by taking careful steps at attention to detail and being prepared and just doing things cautiously and properly. When it comes to discharging patients from the recovery room, there are checklists and there are scoring tools to help you know when it's safe to discharge a patient from the recovery room. But basically what we want is we want the patient awake and relatively alert. We want to make sure that they're able to protect their airway reflexes. We want to make sure that they are ventilating adequately, that they're not having apneas, and that they require minimal supplemental oxygen, and that their vital signs of blood pressure and heart rate are close to what their normal baseline is. And then we want to check that the patient is able to move and they have strength. And for most patients having routine surgeries or anesthetics, this is quite easily achieved, but there's always patients that are in a gray zone, and then we have to make the decision as to whether we should keep them in the recovery room for longer, whether they need treatment or intervention, or whether they need to go to a high care unit. So don't take any chances in discharging patients from the recovery room. And then at discharge from the recovery room, I use this as an opportunity to check my prescription charts for the analgesia or other drugs that I've prescribed for that patient and my instructions that I've written to the ward. And I take the responsibility in discussion with the surgeon of writing those instructions, and that will be around the patient monitoring, patient mobilization, when the patient can eat and drink and what they can eat and drink, whether they need clear fluids, mixed fluids, soft diet, full diet, renal diet, diabetic diets. So I like to write all of that down. And then if they require any investigations later that day in terms of bloods or x-rays, then I also write down specific concerns that I might have for that patient. So going back to the elderly, frail patient having a hip fracture surgery, I might write that that patient is at high risk of falling, and so they need to be in a monitored bed and they need to mobilize with assistance, as an example. Right, so that brings us to the end of this talk. I think a number of these topics, when I was starting in anesthesia, they were quite dry. and they sounded really serious, and it just sounded like super intense and serious. And learning about managing an airway or inotropes or the cardiovascular system sounded much more exciting than just being prepared and attention to detail and focus in theatre and all of these things that like make the job sound really, really serious. But at the end of the day, these things are just as important, if not more important. These are the foundations around which you can build a safe anesthesia practice, and these are about saving or helping those patients that fall out of the ordinary, the patient that has the unexpected reaction, the patient that doesn't fit the normal trajectory. And when things are going well, it seems like anyone can do this job. You just have to give a few drags, you put something in the mouth, you breathe for the patient, it sounds really easy. And the skill in anesthesia is refining your technique to get better and better, to aim for higher and higher levels of care and standards, to try and help a broader range of people and to help have fewer complications. That's what I think. And I hope that you've enjoyed this video. I hope that you found it challenging. And as always, if you have any comments or suggestions or feedback, or you have ideas where we can do things better, please contact us via email. We'd love to hear from you. And yeah, we wish you all the best for the safe provision of anesthesia. Take care and enjoy.